Welcome to the International Centre Goa. We have with us Professor Vikram Patel to discuss various facets of the newest challenge the global community faces in the form of COVID-19. Professor Patel is the Pershing Square Professor of Global Health in the Blavatnik Institute's Department of Global Health and Social Medicine at Harvard Medical School. Here in Goa, he is the co-founder of Sangat, an NGO which has won awards from the MacArthur Foundation and the World Health Organization. Professor Patel's primary work is on the burden of mental disorders, their association with poverty and social disadvantage, and the use of community resources for the delivery of interventions for their prevention and treatment. Professor Patel, welcome to the International Centre Goa under these exceptional circumstances. Let me begin with a very broad question, which is, what are the lessons we can draw, if any, from our recent history in coping with pandemics?
So if we look at the history of pandemics before COVID, I think the most important lesson to learn is that we have successfully managed a number of epidemics through two very important principles. The first is to recognize that local action, grassroots action, is central to control the spread of the disease. And I'm thinking, for example, of the successes we've had in controlling the spread of the Nipah virus in Kerala, the Zika virus in Rajasthan, and the epidemic that broke out in Surat. Think of these three highly infectious diseases, and they never went national. They remained localized. And the reason for that was because of very strong local action, quick action, by very effective district level machinery. And the second important feature really is that we must think beyond an epidemic as purely a health or biological phenomenon. We have to recognize that an epidemic is always an interaction between our health or biological status and our social world. For example, an infection that is contagious can only spread through interpersonal contact, which involves a number of different social actions and behaviors. And so we must engage with the community and recognize that an epidemic is both a biological as well as a social phenomenon. And I think we did this extremely well with the previous epidemics. And those are the lessons I hope and wished we could have integrated in our response to COVID-19.
One of the things that has came up, I think, very early on, once China acknowledged that there was a COVID-19 pandemic, is the importance of freedom of information. China, of course, kept COVID-19 under wraps for at least a couple of months. And do you think that really has made a difference? I mean, to the extent that other countries, except for Vietnam, which immediately caught on and acted very, very urgently, so to say, from early January, and Kerala again towards the end of January, that it might have helped if China had acknowledged the problem early. I mean, not going into whether it was deliberate or not, maybe they simply thought that it could be dealt with at the local level, at the national level, or that it would go away, wishful thinking maybe. But again, the importance of freedom of information, because if we had a head start, perhaps we would not be in the kind of situation that we are here today.
So a couple of things. First of all, I completely agree with you that information, the free and accurate exchange of information, is central to the control of an epidemic, both locally and as well as in the globalized world we live in. An epidemic can now travel so swiftly across the world. Now, whether or not China actually acted quickly enough or not is not for me to say. As you know, there is in fact an inquiry that the World Health Organization has instituted. So I don't want to preempt the findings of that inquiry. But it is absolutely the case that the free and accurate flow of information, accuracy is also very important. It's not just free information, it's accurate information. But I will say one thing, the situation in India has got nothing to do with that. Because actually India reacted when we had hardly a few hundred cases in the country. And even though today we are beginning to think that maybe we had more than a few hundred, we certainly did. The unfolding epidemic in India is actually after more than 2 months of a total lockdown. So, to be quite honest, I don't think we can attribute the failure to control the epidemic in India to any actions or none by China. That is actually not true. It may have affected the spread of the disease in Europe and North America, but I don't believe it affected us in the same way. By the time the infection came to India, we already knew a lot about that disease.
Related to freedom of information is how leaders, political leaders, health experts, the kind of information they, again, you mentioned about, the information has to be accurate, correct. Do you think that in some cases withholding information may also be useful so as to not create a sense of panic, or does it usually, again, going back to past cases of pandemics or epidemics in a very broad sense, that perhaps here, what needed to be communicated, and I think you have written a bit on this, is that the fatality from COVID-19 is low. Yes, it will put tremendous stress on any country's health system. And here in India or in the United States, both countries with very weak public health systems. But COVID-19 has also affected the countries with relatively stronger public health systems as in Europe. So my question is this: yes, freedom of information, but in terms of dealing with it, communication matters a great deal, does it not?
Absolutely, Pushkar. Communication is central. And I do agree with you that I do not think either the scientific community or the media and the government have effectively communicated the important facts about this infection. Let me give you one very concrete example. When the modelers forecasted the number of deaths, as you know, this is the start of the communication process. We now know that there was a huge uncertainty around those models, very large uncertainty, and that uncertainty was never accurately communicated to the public. What was communicated was the worst case scenario, and in any economic model, of course the worst case scenario will be very grim, especially when the uncertainty is so great. So one has to ask yourself a question: when you communicate to a general audience that is not familiar with economic models and the elasticity of these data, how should you actually communicate it? Should you communicate the best case scenario, the worst case scenario, or actually explain that the truth lies somewhere in the middle? And where exactly it lies, we don't in fact know. Similarly, I think the way the media has reported numbers, without for a moment, in fact that applies to the government as well, without for a moment pausing to interrogate what do these numbers actually mean when the denominators are so hugely variable across space and time. So for example, finding more cases in Maharashtra could simply be the result of a very effective control strategy in Maharashtra, because they're testing more people. If you don't test anyone, you don't find any cases. So I think this simple fact that simply reporting numbers is meaningless has also not been absorbed by our media. So I do think communication is very central. I often feel that our biggest fear right now is fear itself. And I think that one has to look at how did this pandemic of fear occur in India in particular. I have absolutely no doubt that has nothing to do with the virus, because the virus itself is vanishingly low mortality. It is actually to do with the way the threat of the virus was communicated from the very first moment. Remember that we were given 4 hours notice to lock down the entire country, something that has never happened in history before. Now imagine for a moment a population that has been historically accustomed to death as an everyday event due to any number of poverty and other related causes that are completely preventable, and that has evinced almost no visible reaction from the government, certainly not the leadership, suddenly being told that in 4 hours from now, for 21 days, you cannot leave your house. That warning was accompanied by a reference to a very holy scripture, the Lakshman Rekha. And in a God-fearing population, invoking that also suggested that on the other side of your house was death and doom. What reaction do you expect? What reaction do you expect? Of course there is going to be terror spreading through the land. And I do feel that this is a great lesson in how communication has created, poorly crafted communication, has created a threat to our society that far exceeds the virus. If today the Reserve Bank of India is telling us that it isn't the supply side which is a problem, there's no demand. Why is there no demand? it's because people are terrified to leave their homes and actually engage in society. And so I do think this is the great tragedy. Of course, we can undo it, and hopefully we will in the days going forward. But if there's one key lesson we have learned from the COVID-19 pandemic, is carefully crafted, scientifically accurate communication is extremely important.
There's a sense, and I think you partly answered that the ongoing pandemic is the most threatening, not in terms of lives lost, or even at the end when we count the numbers, but in terms of its economic impact on nations and their peoples. What this will translate into is growing joblessness, growing uncertainty about employment, and increasing downward social mobility, including increases in poverty levels. Malnutrition, all these things are going to be affected. Could you explain, and this is with reference to your own work on the subject, on the relationship between socioeconomic status and mental health, and how and to what extent that may matter?
Yeah, sure. So first of all, I have to say poverty is the mother of all diseases. It's not my statement. This is one of those cliches that is so true, and especially true in India. Malnutrition, for example, is one of the leading risk factors for premature mortality in childhood and maternal mortality. And, without a doubt, malnutrition has gone up. Malnutrition is directly caused by hunger, and hunger has increased exponentially because people are simply don't have money to put food on the table. So we will see a lot more death due to poverty-related diseases. Exactly how much, only time will tell. But you asked me a specific question about mental health, and we don't typically associate mental health problems with death, except that we now know that they do kill. And I'll give you a very important example from recent history, and that is the 2008 economic recession, which didn't affect India that much because our financial sector, thankfully, was much better regulated, but it affected the US tremendously. And many people may not be aware that amongst the wealthy countries of the world, the US is an outlier when it comes to life expectancy gains. From 2008 onwards, life expectancy has not only plateaued, unlike most other wealthy countries, which continue to show improvement, but actually dipped in working age Americans. And the Nobel Prize winning economist Angus Deaton and his colleague Ann Case have just published a great book called The Deaths of Despair to document the reasons for this falling life expectancy in Americans, white Americans, working age Americans. And they attribute this largely to the disappearance of jobs and to the social fabric of society as these communities understood it. The deaths were largely driven by suicide and substance use related mortality. Now I fear that if these predictions by economists today that up to 40% of the jobs that have disappeared will never come back again, this massive movement of people back to their rural homelands where there is no work either, what this is going to spell in terms of its impact on mental health. We're already seeing signs of that. One of the fastest rising consumable items in India since the pandemic has occurred is alcohol. Alcohol is being promoted as one of the few ways for states to actually earn revenue. I cannot imagine a more perfect storm of joblessness, acute poverty, total disruption in one's social lives, the free availability of alcohol as almost the only thing you can actually do in life right now, and the impact of all of this on your mental health. I can only imagine that we will see another surge ahead of mental health problems and mental health related mortality.
If we frame India's health challenges in terms of old diseases and new, where would the ongoing pandemic fit? But again, I mean, another related aspect is whether we place COVID in one or the other. Pandemics of different kinds have been with us since forever. Relative to other health challenges, again, you have partly answered that, but say TB or road accidents, and you wrote an Indian Express article on TB, how we have never paid much attention to it, and how we have been all too willing to act as far as COVID-19 is concerned. Now, how does it measure to both in terms of COVID-19, in terms of these older health challenges or the newer health challenges, in terms of lives lost and economic costs? You have partly answered that question, but if you could address it more directly.
In absolute terms, COVID-19 is a relatively low fatality disease. The reason why we're very concerned about it is because of the data that was coming from Europe and North America, which pointed to a very high mortality. What we failed to recognize is that that high mortality was largely restricted to older people with chronic other medical problems, and importantly, to certain contexts in which the infection spread dramatically. And which were the contexts? Hospitals and care homes. Now, we are a young country. It's our demographic dividend, our demographic advantage. Less than 5% of our people actually are in that age.
Life expectancy itself is...
Exactly, our life expectancy is up. The fact that our life expectancy is low is in fact our biggest defense against this virus. And so I think we failed to recognize, that's another matter of communication as well, that the disease was, and by the time, by the way, the lockdown was announced, we already knew this. This was not one of the unknowns, this was a known. So I think that is going to be our greatest defense, is that most older people live at home. Most older people live in urban areas where healthcare is actually better. And that the other important recognition is that the infection spreads in closed spaces, and most Indian households and life in India is outdoors. You know, our windows and doors are always kept open. So I think this is going to protect us. We will continue to see deaths, Pushkar, there's no question. Of course, this is a deadly disease. But the proportion, the case fatality rate that we are celebrating is low. It's not surprising to me. Of course, it's going to be low. It's not a deadly disease for people who are under the age of 65. So it's not at all surprising. That said, during this process of containment, what we have done is diverted the entire attention of the healthcare system to one disease. And that was a catastrophically bad decision, because there are many other far deadlier conditions, from TB to diarrhea in childhood to poorly managed childbirth, which is complicated, which has, of course, always been with us and continued for the last several months. And again, as I said, I do believe that it's the most urgent need of the hour is to restore all healthcare services, including the private sector, without any controls, and to designate in every place a particular COVID-19 hospital. The government is doing that, to be fair, but still healthcare is largely unavailable for many routine healthcare problems, and we need to address this as soon as possible.
But there would be people who would say that, look, this is what Sweden did, and now they seem to be recognizing that they should have implemented a lockdown at some point. I mean, but again, I mean, your answer, my guess is it would say that, you know, the epidemiological profile of Sweden, or the, you know, age distribution is of people is quite different than in India.
So I don't think the issue is whether a lockdown is needed or not. I think a lockdown does help in containment in high cluster, high density clusters. That is not what we did, though. We locked down the whole country. Instead, what we're doing now is what we should have done 2.5 months ago. That is active case finding, identifying clusters, and reducing the movement of people in and out of those clusters. This is what we should have done 2.5 months ago. Instead, we're doing that now, and of course, the infection has already spread. And for me, I'll tell you, Pushkar, my biggest fear is the spread of the infection into rural India, where the healthcare system is already extremely weak. It has very little absorption capacity to actually do intensive care. Another saving grace, I'll tell you, one of the other interesting stories that is being scripted as we speak is that intensive medical care may actually do more harm than good. This is another one, because it's a new infection, and, obviously, to be absolutely fair, physicians were responding with what they thought was needed by putting people on ventilators. Now the evidence is emerging that actually the vast majority of people who have respiratory distress should only get, nasal cannula delivered oxygen, not ventilated. Ventilators are highly intensive care kind of interventions. Nasal oxygen can be given by a community health worker. So we are now discovering that the overwhelming majority of deaths that are occurring might actually be because overdoing the actual invasive medical intervention.
But that's the story of public health or health today, is it not? In an increasingly privatized system. where you overdo rather than...
Well, you're right. You're absolutely right. One of the less recognized causes of death is medical intervention. And there are actually accurate estimates now that, heroic medical interventions actually kill more people than not doing anything at all. And so you're right. But, I don't want to make it out like I'm attacking the medical professional here, because they were doing what they thought was best in a scenario where we had no other knowledge. So to just sit around watching someone have more and more difficulty breathing and seeing the oxygenation go down and not do something is also a very, difficult, impossible thing for a physician to do. But the point is, we now know that we don't need to do that. The point is, therefore, as the infection spreads into rural India, we don't need to be investing in hundreds of ventilators. What we need is to invest in adequate oxygen supply, nasal cannula, and trained nurses, paramedical officers to actually provide that in safe spaces. This is a wonderful positive development, actually. And we need to grasp it. This does not require high technology. It does not require huge amounts of money. It requires mobilizing our existing resources in an evidence-based way.
So this is from last week, last month. I haven't come across this, so I'm actually quite...
No, this has been emerging actually for a little while,
okay.
Which is why, in fact, even just today or yesterday, I saw the latest guidelines from, in fact, the Indian Council of Medical Research or the Ministry of Health, I can't remember, actually saying that most people only need nasal cannula delivered oxygen when they need respiratory problems. The other latest guideline, which they should have done right at the beginning, is not to clog all our hospitals with people who are asymptomatic. Let me be honest, 90% of people in hospital don't need to be there. It's an absurdity, right? I mean, we're admitting people because they're infected when 95% of these people will develop no symptoms. Instead, what we should have been doing was what I think in many parts of India, including Kerala, did, is that you discharge these people into home quarantine and have health workers visit every day to make sure they're staying at home, that about testing other members of the family, creating almost home containment, freeing up the hospital services for other medical problems, not just COVID-19, all the other medical problems that continue to affect our people.
Okay, we'll just take a short break.